So next we have the County of Monterey, and Moira, where is your last name here? Sorry. Moira Lewis will be presenting. Thank you so much. And this is their one-pager if you want to take notes on it. Okay?
Thank you.
Great.
So as we get going, I want to introduce you to someone else who will be passing out handouts. Patricia Zarunian is our program manager. So she's the lady that will, she said she's going to do Vanna White. I think really what we're going to do is, what we usually do is present together. So we're kind of a tag team. I'll begin the presentation. What I wanted to do is make sure you had something to take home, so scribble all over this, and our contact information is the last slide. Okay, so if you have any questions. And I also want to begin this by saying what a wonderful behavioral health map this was. Because this is essentially whole person care. This is what we go for. This is what we're hoping to achieve in the end, is having great collaboration between partners and seamless, creating an environment for a client that takes into account every aspect of their life. Because whether we do or not, that's what it is. Forgive me for changing glasses. It's easier to see with the big ones. I have a larger field of vision with the ones I buy at the drugstore than the ones I have in my purse. You have your initial handout, and Patricia created this, and it is just a perfect example, tells you exactly about what the program is. On the other side of this is the referral form, and we'll be sending you by email a fillable referral form. So you have both of these with you. And now we'll move on to the slides. I'm going to move through the slides a little bit rapidly. We only have 15 minutes, and I think the most important thing about any visit that I ever make are the questions at the end. So I'll cruise through these, and then we'll talk about whatever your questions are. So we were asked to follow a format that organizes all of the thinking for all the different players here today, and thank you for that. So we're all speaking the same language. So who are the people that we serve in the Whole Person Care Project? And you can see here it's medical, pardon me, people with multiple medical problems who have mental health disorders, substance abuse disorders, and they are the highest use, highest cost clients. They go to the emergency rooms a lot. They use it as their primary care, and it's also a reaction to many things, including drug-seeking behavior, also ethanol abuse related to treating yourself when you have a behavioral health problem that you don't identify. So we have many readmissions also to hospitals. So these are the people that we're talking to and trying to build trust with and surround with care. Who is the team? The team primarily is a public health nurse and an assistant. LVNs or behavioral health techs or aides are a part of that. So there's a two-person team, and each team carries a caseload of about 40, because the folks that have been lost to the system for so long have very high acuity, as many of you know. And so we want to make sure that we give them the time and develop the trust. And it does take a while to develop trust with people who, not just because of their behavioral health disorders, but also because they've been in the system and have not been necessarily treated all that well by all of us. So establishing trust with them takes time. And then the caseload of 40 is carried, and we will follow them for 1 year. And at the end of 5 years, we will have approached 600 and cared for 600 patients. Our partners are within our department and outside of our department. So within the department is the behavioral health department, and they have the same situation with clients. They have caseloads of about 40, and many of the people have issues of understandable issues of trust. And so we are kind of carrying the same acuity. May I have the next slide? So what we are doing is intensive, comprehensive nurse case management for the most vulnerable, homeless, who have Medi-Cal. We started in 2016, and that was our year of design. So it was built by the people, our administrators and partners within the community built the program. We've been implementing it now. We are in year 2. So it's year 1 of implementation for us. and we have 5 years to do it, and Title 1115 is what is paying for it. Forgive my voice, I'm sorry. I got an inhaler here. Okay, thank you. So why? We wanted to expand the services for the most vulnerable people in our county who are medical beneficiaries. We wanted to improve their health outcomes and their functionality in life and the quality of their lives. So we want to improve the management of the complex chronic disease, their mental illness, and their substance abuse through an integrated approach. So it really is following this model that you all have worked out. It's an integrative approach. So everybody's at the table. You guys also can stop me anytime if you have questions as I go through this. And in the end, what we will do is reduce the cost of care. So by reducing the cost of care, maybe too many trips to the emergency room that weren't necessary and were not helpful to the client, those resources can be used to assist the client and maybe more clients. So reducing the cost of care does have a benefit in the long run to our clients. We can even bring more assistance to them with those resources being reallocated. Oh, thank you. So how are we doing this? First, we assess the enrolled clients for their health, their behavioral health, their history of possible substance abuse disorder, and their social services. And then we use this integrative model that you guys have drawn up here. And we assist the clients with finding and scheduling behavioral health and medical provider appointments, mental health assessments, substance abuse program intake appointments, and therapists. We accompany them to help them to navigate social services, even the DMV. They need that identity card. It's like a driver's license to access care. So we will go with them there. We'll work as we move along. You guys are all familiar with Maslow's hierarchy of needs. So at this point, many of them are toward the level of just crisis. So worrying about their educational job training wouldn't be a priority at this point, but as we move along and carry them along, we may hopefully be able to get that with some of our clients. And I have a story for you in a minute where we're already there. And then we provide transportation and also access to food. We continually assess and reassess both their welfare and their compliance. A lot of that is linked, and again, also their housing. We advocate for clients in any needed setting. So the nurse, and I have gone to hearings, perhaps to address issues of noncompliance with housing requirements, or even to court to make sure that they're not just lost to the system, because they just get frustrated and walk away again, and here we start that cycle again. So it's we team lead in collaborating with partners to integrate every facet of care in the client's holistic environment to provide some kind of lifestyle that is humane, compassionate. Next. Thank you. Okay. Oh, I got this cool. Yesterday, I saw this symbol up there, plus change, and I didn't even know what it was. So I emailed Shelley, and she told me what it meant. It's just beautiful. It's just a cool little thing. So anyway, successes and challenges, what would we like to change? So all the people that we have on our caseload currently, they're all homeless. So our partners helped us to define what that was. In the beginning, they were going to be at risk of homeless or homeless. And our partners who work in the homeless, who work in shelters, advised us that we should change that definition with the state. And we did. We followed what our partners said. So all of them are homeless, and they have a potential chance, if they are homeless, of getting housing. It's the HUD definition. So they're all homeless. All of them have complex medical needs. 63% have mental health disorder. 68 have substance abuse disorder. So you'll see there's more substance abuse disorder than mental health disorder. That's pretty characteristic of the national population, where people self-treat with substances rather than seek behavioral health services. Half have been housed at least once. We do have issues of compliance, being evicted and eloping. And we have been able to get patients exhibiting worsening mental and medical symptoms prioritized into care through collaboration with our clinics, our behavioral health clinic and our county clinics. So when a client is having worsening physical or behavioral health problems, they allow us to get them in there that day, and they see them. So that's been a remarkable progress that we've made with our partners. We build real collaborations with our partners to help the clients and create a system of change. And, oh yeah, so what would we change about anything? Patricia and I were talking yesterday, and we said, well, this has pretty much been like a tsunami, one tsunami after another. But that's what you do. I mean, so would we change anything about it? Probably not. We are trying to respond creatively and productively to everything that happens, whether it's HIPAA and getting consent signed, the sharing of data. So what we're looking at is we're a pilot. There are 24 counties in the state of California that are working on the pilot, and what they want from us is systems change solutions. So we're trying to create a revolutionary change. I've been a nurse since 1979. I've worked in many states, either in hospital or public health, and it's always been the wish of all of us in practice that the client not be sent out, recycled back in, have no resources in the community, not identify what the real issues are, and not really help them with what they want to have happen in the time that they want to have it happen. So the barriers that we are counting are not new, and we're trying to create collaborations that will give us a successful and workable prototype that we can share with other partners in other counties and possibly create a real change to serve the most vulnerable and lower the cost of care. Well, how are we doing on slide? Okay, what are our future plans and possibilities? So what we would like to do is have cross-system data sharing with all of the county hospitals, both private and county, clinics, mental health units, and substance use disorder treatment facilities, the providers, and EMS in order to identify those in greatest need. We continue to increase prioritization of whole person care clients into care, whether it's individual providers or behavioral health clinics and treatment centers, and housing. So that's our elephant in the room, as all of you know, it's housing. We have a sobering center, a respite center, peer navigators, and these are going to be further developed. And Patricia, will you come up if I can move along quickly enough and address these? Thank you. And on-site housing sustainability services, and there are new possibilities on the horizon for housing resources and access opportunities. We have new possibilities for reintegration of clients, and we want this system to be sustainable. So what the expectation of the pilot that they laid out, we would like to have that work, and it is a systems change, and it will contain the cost of care so that these resources can be reallocated in a way that is more helpful to patients. We'll link the systems, a master person index, data warehousing, and care collaboration case management for effective use of resources, cost savings, so that services are efficiently directed where they are needed. So we do have a great cost in going into maybe ED visits that aren't necessary, or readmissions that we could maybe address. Many of these revolve around diabetes, but other chronic complex diseases. At some point, they all become related as a person becomes older and more systems that interact with each other begin to not work so well. So, Patricia, could you come up here and address? Oh, that's us. So, you've got this handout, and you have our contact information, and we'll be forwarding this in the handout itself, and then we will also send the link for the referral form. So, this is Patricia Zarunian, our program manager, and would you talk about some of the upcoming future plans that we have? Will you go back
yeah,
one
can you go
slide?
back one? Okay, thank you. Okay, so we've been talking a lot about sustainability because this is called a 5-year pilot, even though the first year was entirely taken up by the state of California and putting out the RFPs. So we are nearing, and then this is on a calendar year, which is weird, but we are nearing the end of year 2 because these are in calendar years. What we did that might be different from what others were doing with their plans is we were building a lot of a big chunk of infrastructure in with the IT solutions that we had been wanting for years and years. We have an HIE, but it's not as robust as we would like it to be, and so there are some things we needed. One was master person index, so that we could share information at the patient level between all the clinics, behavioral health, all the providers, our housing people, and also the case management software that we need. Because we have case managers, behavioral health has case managers, our housing people have case managers, CCAH has case managers, and but we all do a different type of case management, so being able to share and get into that data is important. This system is going to be built where some of the players will have entire access, some will have limited access, but everyone will be able to load up data and then bring down the kind of reports or see the kind of data that they want to see. And then the last one is the data warehousing system itself. So we have 2 RFPs that have been out, took like months to develop them. And now that they're out, it'll probably take a number of weeks to review them. And once we pick these vendors, it's going to take them almost a year to get the products developed, to get all the bugs out, to have us beta test it, to have us do some training on it, and then it'll be up and running. That portion of our whole person care budget is huge, but it's also lasting for us. And it's going to make these other things that we are doing integrate so much better. So what Moira keeps saying is, to everyone when they ask about sustainability, is that this is going to be our new business as usual. So this is going to all come together. We're going to be able to do what we do in a more integrated way, and we'll just go forward, and this is the way life will be. The products that are coming out that Moira mentioned, we have a sobering center that's coming online. It's being operated by one of our vendors in a building that they have available to them. It's going to be 8 beds. This is going to divert people from long stays in the ER. If they get picked up by ambulance, they'll go straight to the hospital, of course, but then be diverted to the sobering center for up to 23 hours. Usually they're in and out by about 6 hours. We already have 1 respite center in Monterey County. We're going to be building another one with more beds. And this will be for people being discharged but not able to take care of themselves because they don't have a stable living environment. So they will be there for up to 90 days while they fully recover, and our PHNs will go in and address their wounds, their injury. Other professionals will go in and help them recover, and then we'll get them back on the way. Peer Navigator program is something that we're going to be doing in an area that's very concentrated with our homeless population. So these are people with lived experiences that will help us find people who have fallen out of our system, or find people who we have been informed are high utilizers, high cost utilizers, but we can't find them. These folks, we hope, will help bring them to us or give us access to them. And they'll also do things like friendly visits at hospitals to keep our folks, when they end up back in a hospital or in a residential facility of some type, to keep them kind of encouraged. And then we have some other ideas in mind for them too. So the last thing I'll mention is housing, because that's our elephant, right? We have been very, very lucky to have in our environment Chispa Housing, which has been a nonprofit in our Monterey County for 20-some years. They generally build housing for farm workers. And they have since expanded a little bit, housing for seniors, and now housing for people who are homeless. They're going to be building a facility on the coast for us with a wonderful grant from CCAH that gave them money that they were able to leverage. They have promised that 20 of those beds, 20 of the 40 beds will be for whole person care patients, but the other 20 will be for CCAH high utilizer. We're all talking about the same folks, so that's going to be 40-some units. And then Mid-Peninsula Housing, I think you all know Mid-Pen Housing is also building an 88 unit for us, and we are seeking No Place Like Home funds that will help us, again, with housing inventory. And we don't have an emergency shelter in Monterey County. We have a winter shelter. It's basically they open up the armory and they throw cots in. It's not much. So the city is working on creating that, and we'll see what we can do to also add to that to bring our housing inventory up. So.
Thank you. Thank you so
done.
much. Awesome. So we have questions from the back. Come stay up here. Sorry. Okay. So I think Karen.
Hi, thank you, ladies, for sharing that. I'm curious, you in one of your slides, you were talking about some of your outcomes of interest, and one of them was improved functioning. And I'm just curious to know if your nurse teams are using a specific assessment tool to assess and track patient functioning.
Tell a story.
So, oh, thank you. Okay, yeah, I want to answer that question and tell a story. Thank you for reminding me. So yes, not wanting to reinvent the wheel, I did a search for comprehensive assessment tools and plans of care. And I looked at several different states, particularly the leaders in public health around the United States, Massachusetts, New Jersey, Minnesota, and I came up with Georgia. So I put together a number of the components for the comprehensive assessment and plan of care, but it was the state of Georgia that many people participated in creating this plan of care, and it's a continual assessment tool. We've added to it the VI SPDAT and the PHQ-9. Many of you may be familiar with that. So yeah, it's the state of Georgia. I give credit to them everywhere, and that's where the CDC is, if you all remember. So it's a wonderful comprehensive assessment tool.
So maybe if you want to send that to us, we can send that tool out.
Out. Yeah, we can do that.
Thank you. Don?
Thank you. This is more of a commentary. The border between Santa Cruz County and Monterey County is an affectation. There is no such, there's a river, it's a nice river, and there's strawberry fields, but the reality is, those of us that practice in Watsonville and South Santa Cruz County recognize that Monterey, Santa Cruz,
Waivers.
So my point in saying that is I believe that what you really are looking for in terms of a data exchange system needs to be a regional solution, not necessarily one that's only related to Monterey County.
Yes, thank you.
And again, there has to be some interest. I think this group is probably the right way to approach that is, I think the state government is going to have to impose that on various systems to a certain degree. And I think Mr. Monning has an interest in that if approached. The point being is, the medical information systems as currently designed is proprietary interest to keep them isolated one from the other, and we have to break that down basically because we need to take care of clients and patients. So I would submit that what we really need to do is expand the vision that you have, which I think is the right vision in terms of data sharing, from simply one that encompasses Monterey County to one that encompasses the entire region.
Thank you.
Thanks for bringing that up. That's really important. So we have a two-phase implementation, and the second phase is bringing in our partners who have selected access. So what you're saying is, yeah, we have this problem in Pajaro. You know, they belong to both of us, they belong to none of us. We went to the state conference this week and we said, what if people are doing whole person care in one county and also in the other? Are we not going to be able to be reimbursed? Can they access both? What do we do about this? And they said, you guys should work that out. Yes. So, but I will go back. I don't know why our system would limit the number of users and why we couldn't, you know, when this gets going in a year, add more users, which would be, you know, the county, Santa Cruz County, and the hospitals in Santa Cruz County, and the clinics. So, yeah, we'll take that back.
Thank you. You want to share a story? Yeah, I wanted to share a story, and we'll get to your question too. But this is one of our remarkable successes. And I don't want to identify the person by gender,
but I will say one story. One of the people that we have found and as a part of our crew was young and had children that they had lost, removed from them because they had a substance abuse disorder, an addiction to meth. So they were homeless and young. They had an underlying cardiac condition that they were born with that was made many times worse to the point of becoming almost terminal because of the meth. So when we found them, they were young, completely compromised physically. They did have also bipolar diagnoses, had behavioral health issues, and of course self-medicating with methamphetamine. So we were able to touch base with this person, and over a really remarkable period of time, and I must give credit to where it is due, also the sponsor for Narcotics Anonymous was helpful in this, and so the person has housing, is in the process of getting their children back. This is where I want to cry. Has access to behavioral health, is going to the Narcotics Anonymous and Door to Hope 4 days a week, and it's going to happen for them. And the Job Place Training Center, and it's going to go back to school too. So that's what first, when we talk about housing first, we were able to get this person housing because of that sponsor. And then the stabilization of their home helped them to move along. And we've only been really hitting the streets since April. So this is a remarkable turnaround for a person. So these kinds of programs and housing, of course, is really essential. So that's one of our heartwarming stories. We have others that are not so heartwarming as you can imagine, but we are not giving up. That's the other thing, is perseverance. You guys all know that one now. Don't give up.
So there's another question in the back.
Yeah, just logistical. I was wondering, are you still accepting referrals or are you at capacity?
Thank you. So we are way beyond capacity, but that is okay. I mean, we keep talking to our partners and referral sources and explain to them we have a limited number of nurses, and as we go through, and a limited number of teams. And what we must do is we must find the most vulnerable, those who have the most complex needs, the most behavioral health issues. One of our partners in behavioral health brought up something very important though. So while people may go to the emergency very often, behavioral health clients tend to go less and less to the behavioral health clinics. So we can't just look at highest cost, highest use people. Each person has to be dug into. And we have had, that sounds terrible, the history of each person must be dug into. And we have had help in that we have had attorneys, the county attorney and an individual consultant come on, and we have been able to get permission to access medical records, even Avatar. Are many of you familiar with Avatar? Because we need to look at all parts of the client. We don't have permission yet. We're hoping for the Alliance to help us out for people who are not enrolled yet. So that's something that's a part of that pilot too, the ability to look at clients and not violate HIPAA, but with the real intention of helping people. Were there any other questions? Well, you know where to find us.